I guess when it's your own kids too, you just don't think about stuff like that. At least I didn't. I tried not to be overly analytical. I don't know if that's the way you want to put it, but.
Oh, I know, yeah, because you're like, we don't have to look at everything as a problem. She's on her own time frame.
Yeah.
Maybe not this month, but she'll get it.
Yep, you just kind of wait, and then they said that, and I'm like, well, we're getting this fixed right over. So the end of this summer, she'll get both of them fixed.
Oh,
But,
good.
yeah, so that'll be nice to do it both, and it's nice that they do it right in the office now. You don't,
Yeah,
they're there.
it's not
20
like
minutes, you're
yeah.
in and out, and yeah.
Yep. Easy recovery.
Mhm.
So
Yeah, well, it's nice to
Yeah,
meet
nice
you.
to
Yeah,
meet
we
you
might
too.
get to see you
yeah.
in the future once she recovers from her little procedure.
All
and
right.
We'll see how her kids on its own, or if we need a little
Yeah.
help. Yeah. All right.
That's what we do.
Yes, we are ready.
Have a good appointment.
Yeah, thank you.
Good to see you.
Yes, you
If you're
too.
interested in the recording, just shoot me an email or Catherine. I'll send you the recording.
Yeah, perfect. I appreciate that.
All right.
Thank you. You can have it.
All right. Well, it's 6 o'clock. Hi, everybody. It is 6 o'clock p.m. on Wednesday, June 15th, 2022. And I am Dr. Maureen O'Keefe with Purple Mountain Physical Therapy. We are a pelvic health and TM joint specialty clinic, and we work with a lot of pregnant and postpartum moms and children who have bladder and bowel problems. And one of our things that we're doing this year is inviting guest speakers who are local experts on various topics that may be of interest to our community. So tonight we're really excited to have Courtney Joesel here. She's a speech language pathologist with Building Blocks Grand Rapids, and she started her own clinic and treats children in schools and in her private clinic, and she has staff who does the same. And Courtney has some really interesting certifications and experience related to oral feeding issues, including tongue tie, tethered mouth issues, and speech and language delay. So why don't you tell us a little bit about your business and your experience?
Yeah. So I'm Courtney Joesel. I'm a speech language pathologist, and I am the owner of Building Blocks Therapy Services. We specialize in providing, speech therapy, and we are able to work with many different disorders, but one of the areas that as I've grown through my practice is really getting to know the why of kiddos as they're developing, and that has brought us down into really specializing in the mouth. And so
you're saying to get down to, you need to figure out why they're having speech and language problems, and that's caused you to specialize in mouth and oral?
In understanding structure and function. Now, that's not everything, but that's just where my practice we work a lot with. But we also work with those kiddos that are just as they're developing are having difficulties with communicating their needs and wants with mom and dad or others around them, and also through the school. So started the private practice after working in the schools and with other professionals, and we now have 5 other speech therapists and helping lots of kiddos.
Awesome. That's great. She has 5 speech therapists. So where are your clinics located, or how can somebody connect with you?
Yeah, so we are off of Fuller Avenue near the Plainfield exit. And we are, you can email us, call us. We're also on message us on Facebook and Instagram and able to connect.
Great. Okay. So we did have people sign up for this who submitted some questions in the chat. You can feel free to type any questions if you wanted to do that, and Courtney can answer them. Our topic tonight is toddler speech and language development, and what would be the norms for that, and what are red flags? What can a parent do at home to try to facilitate their kids' speech and language development? But feel free to throw other questions Courtney's way if you have any questions about other ages or other issues going on. But I'm going to jump into one of the things that was submitted. One of the things that was asked was if a baby has feeding issues, this person's child had a tongue tie and the tongue tie was fixed. Is the child more likely to have speech issues? So we're going to start with that question because we're going to kind of oral motor development in infancy, and then I guess we'll jump in. That will take us to toddlerhood. So Courtney.
Yes. So when a child has tethered oral tissues, to kind of answer that question bluntly, it really is it depends for many different reasons. So the fetus starts swallowing in utero around 20 weeks. And so they're practicing doing that swallow motion. So if they have some tethered oral tissues, that's going to start once, when they are in utero, because as they develop that frenulum, that string underneath the tongue is supposed to kind of peel off like a zipper to give that tongue some more free movement. Now, depending on the severity of the tongue tie, maybe how there's compensations and when it was released, there might be some other structural difficulties that could have created, such as a high palate, a narrow palate, that can impact where they are able to do the speech sounds, how their tongue fits in their mouth. And also working on those muscles, there's many small intrinsic muscles of that tongue that help with the act of chewing and swallowing. And the tongue kind of does a wave motion like this. And if it's tethered, we can't get that motion. So they're having to use other muscles to help compensate to get that food down, to get their nutrition. So some kiddos, they can have a severe tongue tie, and honestly, the way their body worked, they were able to compensate, and we're not seeing other issues. Other kiddos, it could look minor, but and even if it's been fixed, they could have some compensatory patterns that we might need to address to help them with their overall development of their speech sounds. And so the tongue is really important in speech and feeding, because when a child is eating, they first kind of learn this front and back motion with the tongue. You're kind of thinking about breastfeeding, and then they're also getting this wave. Then if you start to think about when you introduce solids, that tongue has to be able to move that food to the side. So we should start seeing some of that tongue moving side to side. Now, we don't do that for speech, but that really impacts the muscles of our tongue. And then as they start to get that more mature swallow, they start to get more lingual stability and being able to move, which then we see more of the impacts on speech development.
Okay. So I suppose what you're saying is that a child who may have, in this person's question, their tongue tie was fixed. So that would mean they don't have it anymore, or they have it as fixed as it could be.
Yeah. So this is where it goes to, if it depends, that sometimes they're fixed in the hospital with some scissors, and it might be more visual. And then we find out that there's still more tethering going on further back on the tongue, or they could have had it done, when they were, 6 months, a year, 2 years with a laser. And they were able to, get that typical function without some reteaching, then they're probably good to go.
Okay.
But sometimes kiddos just need some of that teaching of what they need to do now with their tongue and muscles of their mouth, because they didn't have the ability to move it in the way that you and I might.
Yeah. Okay. So you are working with babies from birth through whatever. I suppose you work the whole lifespan, including the babies. Okay.
Yeah, I do work the whole lifespan.
All right. So then we progressing more to speech and language. We had a person who was asking about help for developing speech and words for their 15-month-old. So I want to address that question after you tell us what are the speech and language milestones, because one of the things that I think is really impressive for us parents to know is that there are developmental windows in brain development that ideally are hit during those periods of time in a child's life. So those milestones would be something that you're very familiar with. Can you tell us what we all should be looking for from whatever ages that would begin in terms of speech and language?
Yeah, so first thing that as a speech therapist, if we want to even think down to the infant, is their eye gaze. Are they connecting with us? Are they making eye contact with us? That's a form of communication. So we're looking at that as communication. Is there an engagement? And then as they start developing, we're looking for that joint attention. If I'm looking at the ball, playing with the ball, they're looking at the ball and they're looking at me. We're paying attention to the same thing. We're playing with the same thing. We might not necessarily get verbal communication from them, but they're communicating with us. We're sharing this experience together. Then we want to start hearing some babbling around that 6 to 8 month window of, they're practicing getting those lips together. You're usually going to see more of the lips first.
Okay.
So ba ba ba, ma 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 ma. You might start hearing raspberries, as they're figuring out how all these muscles work. And then we want to see some babbling that's switching, and it kind of sounds more like jargon. So adult like speech. So blah 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 blah. When your kid's asking you something and there's no real words, but they're asking you a question because they're using those adult intonations with that. Yeah. So some jargon.
It doesn't sound like English, but it sounds like language.
Yeah. So you're telling me a story.
Yeah. Yeah. Okay.
Yeah.
So that would be after 8 months ish.
Yeah. You're looking at probably 10 or so months, and we see this this time of development can be so different for so many kids, which makes it so hard for a parent to know what to look out for. But one of the main things around that 8 to 12 month range is you want to see that kiddo trying and playing with sounds. That is one of my biggest things. If we have a kiddo that's sitting more silent, then we might want to help a little bit with that. We want to start seeing just sounds and cooing, all of those things out of them.
Now, can you talk about what parents can do to help promote that?
Oh, yeah.
Because sometimes I think we just think the child is a quiet child, and we will talk for them, or we know the child wants the milk because they're having a fit over it. So we just give them the milk without really asking the child to express something for that.
Right.
Okay, so what are the ways that parents can interact with their 8 to 12 month old who might be on the more quiet side, who may not be showing these auditory sounds that you're describing?
Yeah. So first off, I always say to moms who are like, oh, maybe I shouldn't be getting this. You're doing your number one job, which is providing for your child. You're reading their cues. You know what they want. That's always the number one thing. But we can encourage more verbal development. So providing pauses and to give them an opportunity to try to give an attempt to what you want them to say, and speaking in shorter phrases. So I always call it the N+1. If they're talking, now this would be if they're a little older, if they're talking in 1-word phrases, I'm going to show them 2-word phrases. I'm always going to try to be 1 step above them. So now not 3 steps, just 1 step. So if you have a child who's not really using words, you're going to want to speak more in 1-word phrases. So milk. So if a kiddo wants milk and they're, oh, milk. And then give a pause. And you're kind of giving this expectant waiting, like it's your turn. I want you to try without say milk. Because they're going to start thinking it's called say milk. And so you get this pause, and then they do, you could be like, oh, you want milk, and then give them that milk. So children are being more willing to try to imitate at the level they feel most comfortable. So we can't expect a kid to say, hey, I want to get in that red car, right? We'd be more apt to have them say car. So that's what we're going to model for them.
Oh, that's awesome. Yeah, that's really helpful. I think your point about making a pause and giving the child time to process and respond is important because their little brain needs a little bit of extra time to be able to sort through what just came in, right?
Yes, it does. And we do talk a lot, and sometimes you don't realize that you're not pausing and providing an opportunity for someone to take that space. And as a parent, you're probably always on the move, always, you're going on to the next thing. And sometimes those pauses can feel so long. And so I challenge sometimes to try to say count to 5. So, do you need milk? 1, 2, 3, 4, 5. Oh, here's milk. So, and it's okay if they don't say anything in that space, but they know in the future, if they want to try it, that space is going to be there.
Okay, great. All right. And so then moving on to this person's question, with help developing the speech and words for their 15-month-old. So what can they do at that point? And what would be expected between 12 and 15 months? And I suppose 15 and 18 months. Yeah.
So between 12 and 15 months, again, this is where it kind of gets a little tough because some kiddos are their timeline could be a little different. But if I had a 15-month-old or 18-month-old coming into my office, I would be wanting to see about 5 to 10 words from them that are pretty consistent and a little close to the adult form. So if bottle is baba, that's okay. But they have a consistent word for that item.
Okay.
And then so about 5 to 10 words, and I wouldn't count like 1, 2, 3, being as 3 different words. That is just a motor pattern that we get used
saying the numbers
1, 2, 3. Yeah.
Oh, that's not 3 words.
No, I wouldn't.
That's interesting. Okay.
You could. I don't use that because a lot of times they can't use the word just 2 by themselves. Does that make sense?
Yeah.
So I would consider that about 1. They know that.
It's a phrase they know,
pattern.
but it's a pattern.
Yeah.
Okay.
Yeah.
That's kind of a cool little tip.
Yeah, that's more of my personal thing. But so they should have mommy, dad, some pretty important things in their environment, ball or maybe doggy. Sometimes, that's one of the first ones that we hear. And then between that 18th month to 2-year range, we should see a huge line going up here with the amount of words and trying to do our communication. So when you're thinking about a 1-year-old, I always kind of, and how many words they say in a phrase, they should be about 1 word per phrase. Car, go, house, mommy, doggy is going to be how they mainly communicate. When we get up to the 2-year range, it should be pretty consistent 2-word phrases. Car, go, mommy doggy, go bye-bye. They should start doing that. They should start combining. And that typically happens when they have around 50 words. They start putting them together. So we would want to see around 2 years to see about, now if we're talking about milestones versus averages, milestones, on the low end, we'd want around 50 words, around 2 years.
50 words.
Yeah.
Okay.
And that would be, I likely would still see someone in my office around 50 words, just because we would expect a little, we would want a little bit more than that. I would,
okay.
Yeah.
Well, so going back to this person's question about the 15-month-old, you say that 15-month-old should have 5 to 10 words consistently. And I'm assuming then maybe the parents need to kind of pick what those words are and repeat them a lot and give that pause and opportunity. So are there a list of the list could be of 5,000 words, but common words are what? You're thinking like mama, ball.
Yeah, bottle, doggy, ball, car, all those things that they see in their environment all the time. Cup, food, milk. Yes, all of those. So you're really trying to think of those items that mean a lot to them. They're going to be really motivating as well. How many kids do we know the word cookie? So
so that's a good thing. Are there any other tips for that parent who was 15 months old? Because there's a lot of play games you can do, or rhyming or music. How would that be helpful for someone who's got a 15 to 18-month-old?
Yeah, so I always say you want to create these verbal patterns, and then you can start kind of pulling back from them. So one of my favorites is ready, set, go. And so you might start with just having the kiddo, you say ready, set, give that pause, give that expectation. They finish and they say, go. So that could be on the swing. Then next time, and then as they get used to that, then it's ready. And then you want to say set, go. Yeah.
Yeah.
And then the next time you just get that, because they're going to be used to knowing exactly what that is. And that's why songs like Old MacDonald or, Twinkle, Twinkle, Little Star, they're repetitive. We say the thing over and over. And so their brain starts to expect it, just like if you're on a bus. I lived in London for a bit and was on the tube, and they'd always be saying what stop it was, but I could never hear them, but my brain could always fill it in because I knew that route, I knew that pattern. And that's kind of what starts to happen to them. And that predictability and structure is there for their brain to be able to perform a little bit better.
Oh, that's awesome. Okay. So now let's go into another question. It's a little bit of a longer question, but it's revolving around a 2-year-old. And this is a 2-year-old who may not be hitting the speech milestones, and the parent is recognizing that. So what this person wrote is, I have a 2-year-old that barely has 3 words. Now, you also said that by 2 years, there should be this huge increase in at least 50 words. This child does have 10 animal sounds and 10 or so sign language vocabulary. The child had a state assessment, but the state says that he is not delayed enough to qualify for any kind of support or therapies, but that he has a minor delay. The question was, do you have a home recommendation or how to proceed with professional assistance and support? They're planning to have him reevaluated at 2 years, 10 months if they don't see progress. Many thanks for this free talk. Well, I'm glad that you signed up. So there's a lot in that question there. So go for it, Courtney.
So one of the first things I actually want to talk about. So I worked in the schools for years, and then I've also been in private practice, more in the professional setting of it. And there are actually 2 different models that we have here. We have the educational model, and then we have the medical model. Schools go with the educational model. Private practice professional offices go more medical. So the educational model, this is all state run. As you said, it was a state assessment. There are specific criteria that children have to meet in terms of delay for them to qualify for these services through the state. And they set these, people get in a room that we don't know, it's a mysterious room, and they're gonna set these standards. Okay, these standards can be, I don't want to say pretty extreme, but they're looking for a certain amount of delay. They're not saying any delay. They're looking for a certain amount for them to be eligible for those services. They're not necessarily giving a diagnosis per se. So you can have a kiddo who is showing a deficit or a disorder, but they didn't necessarily meet their eligibility for those services within the school. Then we have the medical model, which is, do you have a diagnosis? Is it medically necessary to get services? Yes, let's get services. Okay, and we use similar assessments. We just might have different standards of what we're doing. Educational, they're talking about their ability to get access to the academics and educational experience. We're looking at, is this medically necessary? Is this kiddo able to communicate their needs and wants? Are we seeing functional communication? Various aspects of their life.
So the speech therapists are probably in a school, are probably similar to a physical therapist in a school. A physical therapist in a school has to have everything related to learning and school performance. And it's really hard to qualify for physical therapy in a school setting. Your child can have a lot of problems, but if your child can sit in a chair and hold a pencil and walk around the school to get from PE to the room, you don't qualify for physical therapy under that.
Exactly.
Speech is the same?
Yes.
Yeah. So this person who wrote in, it sounds like maybe they went to one of these programs that basically doesn't qualify for people for therapy, but based upon this 2-year-old having 3 words 10 animal sounds.
Yeah.
That sounds good.
Yeah.
And 10 or so sign language vocabulary. That's good. Communication is there.
Mhm.
What do you think?
Yeah, well, it sounds as though they did identify a delay, but a
They did.
mild one. And so that in likely, absolutely not seeing this kiddo would warrant some intervention. And so I love, first off, that the child was already evaluated. Even if they didn't qualify for the state services, I just love that they were evaluated. That is the first step.
Yeah.
And to get the information that you need. Knowledge is power. And so there is a huge, as you talked about earlier, these windows of time to when that brain, those neurons are really trying to figure out, all right, what do you want me to do? And this is a really big sweet spot for the kiddo to really try to close any gaps that they might have, instead of prolonging any interventions and making that gap get bigger. So my suggestion is do some of the techniques that I talked about, speaking in those shorter phrases, and giving those pauses. But I would say that you asked a little bit about those professional services, that I think a great next step would be to go to more of a private practice or clinic, to then also have them kind of have a look at it. Always bring that other evaluation too. It's always really helpful for any speech therapist to see, because we really don't want to do the same assessment with the kiddos, because giving it in too short a period might not be the best. But then we can really talk about how can we help and give more power and communication to this kiddo.
Yeah.
Mhm.
Well, and this mom, well done, parents. I don't know
Yes.
if this is a mom or a dad who submitted this.
Yeah, sorry.
But well done.
Mhm.
You are on top of it. And if they
Mhm.
are suggesting that you have a follow-up visit at 2 years, 10 months, what I just heard was, I think maybe you need to get on this sooner,
Mhm.
because you're in the sweet spot of developmental growth, and having your child privately assessed in a proper speech therapy clinic would be a different assessment and would provide you with a little more support too. You're doing a great job,
I know.
because I could tell this is a parent who's totally on top of it.
Yeah. And I always say, one thing I get asked a lot is, when should I get my kid evaluated?
Yeah.
Some parents feel like they need to wait a certain amount of time to get a speech language evaluation. And I always say it's important to just see than to not wait and see. You just need to see.
Mhm.
And a lovely thing about speech and language evaluations with kiddos is that we play, we have fun. They get that time where all of our attention is on that kid, and they typically have a blast. And then we get to provide the parent with some information on where their child is at, and then make some great next step decisions.
Yeah. Yeah, I had one of my kids assessed, and it was great. They actually brought a speech person in, and then just a developmental person. I don't know that was her area. It was in another state. It was very helpful. They went through and checked off a lot of milestones, gave me some tips. All right. And then there was another question. Well, how do I know if the speech for my child is a problem or if it's okay? Maybe he's just quiet.
Oh. Mm-hmm. So my brain initially goes to, is this when we talk about speech, this is where my speech therapist brain goes, we're talking about speech sounds or language. So speech and language are kind of two different things. Speech is like the sounds that we say, how we form them with our mouth. So you can still say tar for car, that's more speech. And the language is car. Okay. But hearing the word quiet makes me think more language, not saying as much.
Okay.
Okay,
wait, I'm still not understanding. I missed that. Okay. So speech is articulation and how it sounds.
Yes.
Language is the ability, it's like comprehension and the ability to
formulating it, being able to communicate your thoughts and ideas. Or organization of that.
I see.
So, but hearing the word quiet makes me think about the formulation deciding what words to use, when to use them, how to use them.
Oh, interesting. Okay.
Yeah.
Uh-huh.
So if they're quiet, I would look at them in various environments. Are they more quiet in certain environments, or are they always like this across the board? Are they able to get their needs and wants met? And how do they go about that? So because we don't know the age, I'm going to give a couple levels of examples. So let's pretend it's a toddler. We're not hearing many sounds. How do they get the milk, or how do they get the cookies when they really want them?
Mhm.
Is it that they're screaming and crying? Is it that they don't even ask for them? Or is it that they're really looking and they're really trying to figure out how to tell you what they want? So all those would mean different things to me. If there's a kiddo who's really at that age, around like the one really trying to figure it out, I'd say we're probably gonna be okay if they're really trying to figure it out. But if we're resorting right to behaviors on a consistent basis.
You mean like temper tantrum screaming?
Yes, yes.
Oh, you don't want that. Use your words. That's what all the moms all say. I was saying that
But
all the time.
behaviors are a form of communication. So when we see that, it's okay. Let's pedal back a little bit, see what was he trying to communicate, or what was she trying to communicate. Now
I saw, on that note, communication, I saw the coolest viral like TikTok or something. It was a child that was pretty young, maybe 2.5, possibly 3, and was too short to reach the kitchen counter, but on the counter was the cookie.
Yeah.
So the kid had a major temper tantrum, and the mom has the phone on it.
Oh gosh.
And the mom was so amazing. It was like she was just some like Zen cool mom. So she says to this child, which the kid's crying, like demanding the cookie. She says, use your words and breathe now. And she's like, breathe in, breathe out, breathe in, breathe out. And you can see this kid just dial down their nervous system and their emotional control. And the kid is like, and then it gets more controlled. It was so cute.
Yeah.
And then, but after like, it was not even that long, then the mom said, what is it that you want? And I don't think the kid was able to really like string together a full sentence, but at some point they communicate verbally that they want the cookie, and the mom said, okay, you may have the cookie now, and gets it was like this beautiful self-calming, use your own breath to calm yourself. And that could be something similar to what you might suggest to parents. I'm sure you have lots of ways of suggesting them to modify the child's behavior when the behavior is very demanding, whether it's crying or demanding or.
Yeah, it's normal for toddlers to have temper tantrums. That's part of their developmental milestones. We expect it. But if we're constantly using the behaviors for communication, then we might need to consider something. Then if we think about a little bit older, so let's think about like a 3-year-old or so who might be really quiet. Is it a kiddo that, I would be curious if they're interacting with friends. How are they, how are they playing with friends? Are they using language? Are they doing pretend play? Do they pretend, dinosaurs are, fighting and talking and I'm going to get you, or Barbies. We want to see some of that like pretend play talk.
At 3 years old?
And really kind of, don't quote me exactly on that.
Right. Yeah. I know it can start younger than that, and it goes beyond that. Yeah, I understand.
But so we would want to see, how are they practicing this, working on those longer phrases. But if they're, a kiddo that's kind of sitting at a lower word level, then we might want to kind of say, is their vocabulary low, or what's going on with that. So it's just like a couple ways to think about that.
Well, that's helpful tips. Okay. Another question that was asked are, what are some important feeding milestones? So we're going back to infant feeding and progression, I suppose, to solid foods. And so let us know those.
So introduction to solids is a really important period for kiddos. So, there's that window. Some say as early as 4 months you can start. Obviously, you got to talk to your pediatrician, but we want to really kind of think about that 6-month range of introducing those, because this is when the kiddo is going to start practicing using those different muscles in different ways and managing the food in the mouth. So some really important milestones is that tongue moving over to the side. So maybe when you think about the little puffs and you put the puffs, you want to see that puff more on this side of the gum, not necessarily in the front, because that's really going to work exercise this part of the face. And that's going to be the stronger muscles for them to use. And they learn to have that tongue follow the food. So that's so the food really isn't getting lost in the mouth. And so they have control over that. So that tongue moving side to side is so important around that 6 months. And honestly, with infants, even if you touch their gum, their tongue should follow where that pressure is. That's a reflex.
Interesting.
Yep. And then another thing we want to see is we want to see a lot of up and down chewing of that food. So between 6 months to, it can be all the way up until like 3 years, you kind of see this up and down that food's going. But what we want to start seeing are at like 3 years of age is what we call this rotary chew. So that's where it's not just an up and down, there's a little circular movement of the jaw that helps. Yeah, if you really want to think, yeah, it's really tiny, but it's like an alpaca. Think about a cow or an alpaca. Okay, they have a great rotary chew. And so, but that's a more mature chew pattern. It's going to help them be able to manage those more difficult to eat foods, such as like grilled chicken, steak. It really helps break those down for proper swallowing when it comes to that. I always recommend, making sure that they're drinking out of straw drinks and straw cups and open cups. You can start as early as 6 months, but at least around a year, should be doing that. I highly recommend trying to avoid sippy cups as much as you possibly can. Sippy cups, I say, are not a milestone.
But we don't want it spilled all over our couch.
I know. There are some really ingenious cups out there that are not sippy cups that do not spill everywhere. And one of my recommendations for that is it's always important to, because I get being a mom that messes carpet. Is having a safe place for the drinks, and the kiddo knows that when they're thirsty, they can go up and get that drink. They can have the drink there, and then they set it back down, and then they go back, and creating that pattern for them. Not every kid needs to be walking around with a cup in their hand all the time. So that's one of the recommendations I do for that. Although helpful. That's an ideal world, we all know how the real world goes.
Yeah, that's true. You're saying the sippy cups don't help promote oral motor development and tongue development the same way a normal cup would be, and even a straw is better.
Yep.
Because they have to suck. There's muscles or something.
So a sippy cup, if you think about that hard spout, it goes into the mouth and it pushes the tongue down, and then we get a suckle pattern of the tongue to draw the liquid in, where we should be having this wave motion. Yeah, and a straw should typically be in front of the teeth, so they're drawing from there, so that tongue's able to elevate and do what it needs to do.
Interesting. Okay, straws win.
I love teaching straw drinking. So.
Oh yeah. Because the straws don't usually spill as much. Anyhow,
no, they don't. And there's some great cups out there, like take and toss ones that have a straw in it. Those are great, and they get destroyed. It's not going to bring the bank either. So
great. All right, there you go. Okay, you are pursuing, you're educated in or have postgraduate training in oral myofunctional therapy. Yeah. And you're continuing to do more education on that. So tell us what that is.
Yeah. So this is an an area of speech language pathology, but it also incorporates orthodontics, dentists, anybody who is working within the structures of the face. And the philosophy is understanding that structures of the mouth and face are going to impact the function of our muscles, and vice versa. Muscles can impact our structures and how they develop. And so it's really looking at the relationship between the muscles and structures and how are they working together. So for example, if we really want to look at like speech production per se, when we're doing our speech sounds, which if you were to sit there and say the alphabet really fast, A, B, C, D, E, F, G, right? Your tongue kind of goes up, well, it should, and you kind of stabilize your tongue up in between your teeth as you're doing it. Now let's pretend that you have a really small palate and your tongue can't fit up there. You're going to have to adjust how you're saying things. So for example, one of my favorite are those kids that might mumble a little bit. You're like, oh, can't talk. I can't understand them when they're talking in conversation. When I say the word elephant, I can do big movements, but if I were to say it real quick, elephant, it's a really small movement. So fine motor versus, those. And how are the muscles compensating with the structure and function, and really looking at the underlying concern. So sometimes when I'm looking at this, I might go, oh, this kiddo has some structural concerns or adult, that I want to have it addressed first. Another thing we really look at is airway. Airway is so important. The number one goals of orofacial myofunctional therapy is having our tongue resting up in our palate, lips together, and nasal breathing. Those are our goals. But we can't achieve those goals if we can't breathe through our nose. So we need to make sure that airway is clear. And those I always kind of talk about are those kids that you see in that open mouth posture. Yep.
Yeah.
Those are kiddos that are typically, we need to go look at what's going on. That can change how the jaw is going to develop and how their teeth fit together, which then in turn can possibly affect speech production, airway, and how all these things just work together. And we call them putting on like our myo eyes. And so really looking at the whole picture and foundations versus just the symptoms.
Yeah. Well, they say that you can correct me if I'm wrong, but the tongue is supposed to rest up on the hard palate, and that pressure of the tongue all day long kind of helps as you're growing. You're a little kid, you're growing, it helps the roof of your mouth grow and expand to create room for your adult teeth to come in. So if you're like a low tone air mouth breather, or maybe of normal tone, but your nose is always clogged with allergies, you're losing the capacity potentially, right? To help your tongue promote the development of your hard palate.
So when we're breathing and let's say we have our correct rest posture and that tongue is up, your tongue's in the palate, you can't get air in your mouth because your tongue is in that space. So you have to breathe through your nose. Now, let's pretend our nose is plugged or there is a very small cavity. So how are we going to get air? Well, that tongue has to go down, and that's how we're going to get air through our oral cavity. So that's what can happen if we're not having that constant pressure on that palate, which there is a clinician who her name's Linda D'Onofrio. She says that the tongue is nature's palate expander and our lips are nature's braces, is what she says. And so if that tongue isn't resting up there, then we get what we call like a palatal collapse. And so then those teeth start getting a little bit closer. And then as the new adult teeth come in, that's when you see those kiddos with lots of crowding. They might have their front teeth are a little bit more forward. Teeth can tell me a lot about what is going on in that mouth, and where that tongue likes to be. There's sometimes a kid can smile for me and I can see exactly where their tongue likes to sit because their teeth won't grow in all the way there because the tongue is constantly there.
Oh, interesting. So they'll have a short tooth?
Yeah, so we call that an open bite. So there's a space where when they bite on their back teeth, that you might know those kiddos too that have pacifiers. You can kind of see the hole in their teeth. where a pacifier might sit, and that's because something's always there. Teeth will only grow as far as something stops them.
Interesting.
Yeah. So.
Okay. So then let's talk about those pacifiers.
Yes.
What's the word from a professional?
So it's up for debate on when, but so pacifiers are there for a reason. I encourage that, infants are using pacifiers. That's a way to help them regulate themselves. I usually say around, so some say as early 6 months, just get rid of it. I actually say around 18 months is the time that it should be gone. Even at night, I get a lot of people say they only have it at night. Well, that is 8 to 10 hours of that pacifier sitting in that mouth. That's still a lot of time. That is a third of the day. So, and it's not encouraging that tongue to be up. So, a pacifier is important, for them to start to learn to pacify themselves, regulate themselves. But around 18 months, in my experience and what I've heard is, they have some emotional attachment to it at that point, but it's a little easier to remove it from their life. But when you're looking around that 3-year-old range,
it's much more difficult to
say
say no more passy.
Yes, because there is a big emotional attachment to it. And then I start to go into the phrase, well, why do they need the pacifier till 3 years old? Is that because the reason why you want a pacifier or kids suck their thumb is because they're trying to stimulate where the tongue should be? So then, I shouldn't say always, but it's a theory out there, right? We have a nerve that kind of comes down there. Yeah. And typically they're looking for something to replace the tongue to be there.
Okay.
So if I have a kiddo that's struggling with thumb sucking, struggling with getting rid of pacifier, my number one thing is, okay, what are they trying to fulfill? And then going from there.
Interesting. Okay. So getting rid of the pacifier, you think needs to happen around 18 months, but some people say 6 months.
Yep.
And once we go past 18 months, we might be causing some issues because the tongue is supposed to be on the hard palate. And that's 3 years, or whenever they're older, they have a huge emotional attachment to it. So it's harder to get rid of it. Okay. That is very interesting. Does the pacifier change or potentially harm speech ability?
Yes.
Yes. Okay. So what are the
research
things there?
on that?
There is. Okay.
So when kids especially are talking when they have the pacifiers in their mouth, what they're learning to do is a totally different movement of their tongue. So sometimes we get those lateral lifts because they're talking around the pacifier. And so
you do that very well.
So we get abnormal tongue functions with that. And so that's something that we can see with that. And
so then when you get rid of the pacifier for a child like that, you would be giving them exercises and games to try to retrain the tongue motor control because they don't have that.
Yeah, and when they're super young, we got to be really picky, really tricky about it. We can't sit there and tell them, well, you need to put the tongue up to the top of your mouth. That's not how that works. There is some confusion out there about when orofacial myofunctional therapy starts. People do talk about it like with infants, but they're not doing orofacial myofunctional therapy. What they're doing is feeding therapy. It doesn't turn into orofacial myofunctional therapy until they're old enough for us to give them a direction. They're able to internalize it and then go and do something about it. So it takes a lot of internal monitoring. So sometimes we can do a 4-year-old, depending on the 4-year-old, but typically it's around that 5, 6, 7 range that we really work on that. Otherwise, we're doing feeding. So we're trying to manipulate the situation to get what we want versus us telling them and them actively doing it, if that makes sense.
Yeah. So you're saying 5, 6, 7 years old or beyond that, they can more receive instructions on what they need to do, and they can try to learn and do what you're telling them to do.
Yeah, because we're also then saying, all right, you need to make sure that tongue's on the top of your mouth when you're in school, when you're reading, when you're doing all those, which we wouldn't expect a 2, 3, some 4-year-olds to do. So there's just different ways that we would work with that. And so that's considered feeding therapy.
Okay.
I know there's a little bit of confusion out there, because some families will, they'll bring an infant and they'll say, we're here for myotherapy. And it's, okay, you're here for feeding therapy, but but the approach they're looking for is us understanding airway and the structure and function.
I see. Okay.
Mhm.
Can we talk about the masks that had to
Yeah.
be worn by children? Because I had somebody say to me that the masks are now gone in this child's school. And the mom is noticing that the child who's in middle school, that the child is drooling a lot nowadays. And the mom's hypothesis is that when the child was behind the mask all this time, he was mouth breathing.
Yep.
And got used to that. And it's a child who already has been in physical therapy before and has had some speech before. So she thinks that maybe he now needs like a little tune up on what you're talking about.
Mhm.
Are you, just give me your reflection on maybe that scenario and generally about the masks?
Yeah, so that scenario, I'm actually going to pull in my personal experience. I noticed when I was wearing the mask, I was doing more open mouth breathing. That doesn't mean that other people were, but I did notice that in myself, partly because this is what I'm trained to do. And I was like, oh, that's
Why am I
interesting.
breathing
Yeah,
with my mouth?
exactly. That was just an observation I made.
Yeah.
And so there very well could have been. We know that, as kiddos, they're going through, they can get, wet. It gives a different sensation on the face. So, if this kiddo might have, worked through other things, I don't know. That might just been something that really, the sensation and how it fit, on the face, it created a little bit more of that open mouth posture.
Plus, if it's hard to breathe through the nose a little bit, but you put a mask on and it's harder for that kid to breathe, I don't know.
So that very well could have been. So that might just involve, having to work on getting that tongue up in that palate, doing, making sure we're retraining that nasal breathing. When I look at that. Now, when we look at masks, like in the population, so ASHA, our national organization, did put out a statement that that masks were not impacting the development. But one thing I did notice,
We're not.
Really? Yeah, there's some debate about that. One thing I personally noticed is that there was just some social cues that were missing.
Yeah.
And I think that just where I personally in my clinic just experienced more of that socialization difficulties. I can't really comment on if there was more articulation or any of that. But one thing that stood out is that the interactions with others, just we were needing to work a lot with that.
Yeah, a lot of parents talk to me about that. I'm worried my child has no friends. She's spent 2 years and it's really been limited. And I have another patient who's mentioned she just isn't convinced that the ability to read emotions was there with the child wearing a mask. So yeah, that is what you're saying. You were seeing something similar to that, the socialization and things.
Yeah.
Okay. There are another question about encouraging speech and language development. So let's take it to older, because I think you covered that 15 months, you covered it for 2 years. One other thing, you said at 2 years, there's like this major, increase in speech and language. So at 3 years, what should they be doing? I don't think you said that.
So the CDC did release new milestones, as you know.
And they were not good, right?
And the CDC said at 3 years, they should have 50 words. Is what they said in the milestone.
And everybody in your profession was up in arms. I saw all your posts online. So I would listen to the professionals.
Yeah, I don't know how many speech therapists were in that room. A 3-year-old, they should be putting 3 words together. I mean, we're thinking, you should be thinking thousands of words, 1,000 or so words coming out of that kiddo. That would be ideal. That's ideal. Now that's not like a milestone, but there should be, with a 3-year-old, you should be able to have a back and forth conversation with them.
Okay.
And you should be able, as a parent, as a primary guardian, you should understand that 3-year-old about 80% of the time.
Okay.
Okay.
Now, what about, should the aunt be able to understand?
So that if it's a little bit less is not bad. But you know, the parent should pretty much understand a 3-year-old, you know,
Okay,
almost every time.
all right.
And I gauge a lot about the parents with a grain of salt.
Okay,
So
I see what you're saying.
yeah.
And you're saying you should be able to understand the verbal, what the kid is saying,
Mhm.
as opposed to, oh, I know what my child wants all the time because he
Yes.
points.
Yeah.
That's different. You're
Yeah.
saying 80%, this child ideally would have about 1,000 words
Yep.
and be stringing together 3-word phrases or more. And 80% of the time, you know what they're saying.
Yeah. So like if he was outside and he comes running inside and says, you know, telling you about the ball that rolled into the road, would you be able to understand that without having been there and knowing the context?
Yes. Okay.
So that's the way to kind of think about that.
Okay, that's helpful.
Mhm.
And what about children that are, now that we're in the 4-year-old pre-K room and we're heading to kindergarten? What should we see with speech and language?
Yeah, so around 4, they should have the majority of their speech sounds. And so
should those sounds be pretty well spoken? Like they shouldn't be.
there shouldn't be any intelligibility concerns.
Okay, it shouldn't sound funny.
No.
It shouldn't sound like baby talk at 4.
So they should have most sounds. So that pesky R, we hear about that R.
Yeah.
That we want to see more around 5. So you
Okay.
still might hear a 4-year-old say, you know, look, I got a wing. And that's
instead of a ring.
yes.
Okay.
And so, you know, a 4-year-old, I might go, we're okay. Now a 5-year-old, we would expect them to have that R. But like an L, so if they want a lollipop, you know, we should be able to, you know, hear the L and not a wowie pop. So
at 4, that L is well articulated.
yeah, like the SH,
Okay.
the CH, all those should be around 4. S and Z, they should be pretty good. Then there's some outliers out there, which is the R and the V sound. They're a little, and the TH that are a little bit more difficult patterns. But for the most part, a 4 and 5-year-old should be well understood.
Okay, so if your child is going to kindergarten and is not well understood, I know we already talked about private speech therapy would be really more recommended because you're going to be getting exactly what your child needs, whereas a school-based therapy is going to give you what your child needs to perform educationally. Would a child who does not have what you just described for a 4 and 5-year-old who's entering into kindergarten, who is not achieving what you think of a speech, do they typically qualify for speech therapy at school? And would that be enough? Because I know a lot of kids that are like twice a week, they get 30 minutes with the speech therapist. Is that enough?
It goes back to it depends. Every district has its different eligibility requirements. And a lot of times if their kiddo has one speech sound error, they're typically not going to qualify. But like I said, every district is different. But if there are significant, you know, intelligibility concerns or ability to communicate to the teacher, to their peers, they typically will qualify for services. And, you know, it's important to ask how they provide the services too in the school. Sometimes they provide it in groups. So they might be, you know, twice a week in groups with like 3 to 4 kids, you know, for a half hour. Sometimes they do like kind of quicker tick things where it's 5 minutes 3 times a week, but one-on-one. But, you know, so it's important to ask how they're also providing the services too.
Okay. Well, that was really helpful. We've answered all of the questions that were asked and then some. Why don't you tell us where people can find you? Are you on Instagram? How can they follow you? What's the best way for them to continue to tap into your wisdom.
Yeah, so we are on Facebook, Building Blocks Therapy Services. We are on Instagram at Building Blocks GR. And our website is buildingblocksgr.com, where you can read up on our other therapists and the great things that they're also accomplishing, because I love my other therapists, and they keep me going every day. And we also offer free consultations. So if you just have questions, just give us a call, and you'll be able to talk to one of us and be able to help you for any possible next steps. Great.
And do you only treat up to 18-year-olds, or you treat adults?
We also treat adults. So we treat across the lifespan, and we all have our little own areas of specialties, and we're always able to find the best fit for everybody.
Great. Okay, well, I so appreciate you
Yeah, thank
coming. This was
you.
fun to hear your insights into things. When she and I first met, I felt that I met the speech therapy equivalent of our team here in physical therapy. Like, we love our world of pelvic health and TM joint syndrome, and she is so passionate about it, and so is her team. So if you're looking for high quality speech therapy in Grand Rapids, you can reach out to her team. And if you need any pelvic health or TM joint therapy, we are here at Purple Mountain Physical Therapy in Grand Rapids, and we are so grateful for anyone who attended. You can follow me on Instagram at Purple Mountain PT, and that's where you're going to find out about all of our speakers. We have an excellent counselor who's going to be speaking next August, and some other cool people lined up to share their wisdom. Thank you all so much. It's been a great evening sharing it with you. Take care.
Thank you.
Bye. Thanks for joining.